What I want to talk about, and so I always like coming to the DART meeting because Ray Charles puts on a very relaxed environment where I feel I can just basically get up and give my opinion and talk about what I want, and if it pisses you off, that's great. We can have some discussion. And I'm going to do that. But I'm going to talk about where I think that we need to be going in the cure field, and how we're going to get to where we need to get in the next 10 to 15 years. And I'm going to basically base my perspectives on the fact that I think that we need to study natural models of control. I'll talk a little bit about elite and post-treatment controllers. And we need to begin to leverage all the work being done in the non-human primate model and to begin to start doing more serious clinical trials to see if we can move the dial forward. And why I think that is why I'm going to, is hopefully the take-home message from my presentation. But first, some background perspectives. Okay, this issue of HIV cure versus remission. Right, so HIV cure is generally defined as the complete and total removal of all replication competent virus from a person. And this is obviously what we want to do. This would actually remove stigma because people don't like feeling HIV positive. We think this is probably the most important driving thing for a lot of people with HIV infection. So ultimately we want to get to this point where we actually have a complete and total cure. The problem with that is twofold. Number one, it's going to be very difficult to achieve. And number two, we're never ever going to know if we've achieved it, right? It's impossible to prove a negative. And I'm going to give you an example of our patient, Clark Holly here, who told a very compelling and moving story about his experience in a clinical trial that we recently completed with AMFAR funding. And here's the story. So Clark is a gay man who came out recently and basically said he had a lot of catching up to do, having been in the closet for 40 years, and so he was quite active and had a lot of exposures, and decided that he wanted to go on PrEP. And he came into a clinical trial that we're running to do PrEP, and he basically screened in for the PrEP study, was HIV negative. Came back 3 days later, and I had a viral load of 51. And he started PrEP on that day. Okay, he started his antiviral therapy on day one of Phoebic 1. You cannot start antiretroviral therapy any earlier. A day earlier, we would never have known that he was HIV infected. So when we realized that, we switched him from PrEP to standard antiretroviral therapy, and we slammed him hard with treatment, and we studied him for 2 years. And he had nothing. No antibody tests were positive, no T-cell responses were positive. There was no HIV anywhere in the body. His reservoir was completely negative, as far as we could tell. We were pretty sure that he was HIV uninfected. So he stopped therapy, and then we didn't know what to do, okay? So this was, we monitored him weekly. He didn't know if he was infected. We didn't know if he was infected. If he was infected, the virus would come back pretty damn quickly because he had no pre-existing immunity. He was sexually active. He didn't know whether he should inform his partners. Should they be on PrEP? Should he go back on treatment? I mean, it was basically a mess. And we did this every week, week in, week after week. He came back in, am I infected, am I infected, hasn't come back yet. It was quite stressful for us, and I think also for him. And after about 9 months, the virus actually did rebound. So in hindsight, he did establish a reservoir. The reservoir probably calculated had about 100 to 200 replication competent viruses at the time he stopped therapy. And he went back on antiretroviral therapy, and he's fine. And to be honest, I think we're all basically relaxed now because at least he now knows what's happening on a day-to-day basis. My point here is that as we move forward in the cure area, we're never going to be sure that people are cured. We're always going to have this concern. So I think that all the approaches that we're taking in the HIV cure field are going to require not only efforts at getting rid of the virus, but having a sustained immune response that can actually control whatever virus is left, just in case. And this, of course, is what a remission is. So there's this big debate. Should we do cure? Should we do remission? I think they're the same thing at the end of the day. And what I'm going to talk about now is how we're going to go after remission, which is generally defined as, yes, we know the virus is there, but we need to control it indefinitely, and we're going to do so with the immune system. And we think we can achieve this because of what we've achieved in elite controllers and post-treatment controllers. Now, a question always comes up in these types of situations, is it better to be on treatment or is it better to be an elite controller? And the reason why it comes up is because, you know, elite controllers have a lot of chronic inflammation and they have consequences of the virus and their control, and people often go back on therapy. So why are we using elite controllers as a model for remission when we put elite controllers on antiretroviral therapy? All right, so this is an issue that comes up all the time. Here's my perspective. I want to talk a little bit about elite control and also about post-treatment control and why they're different. So what do we know about elite control, right? So there's been hundreds, probably more, studies done of elite control in people, and we have found out at the end of the day that CD8 T cells are very, very important. They may be sufficient. And the characteristics of CD8 T cells in elite control, multiple different properties have been described in terms of what we want from our ideal CD8 T cell response. That's fine. But the problem with this persistent inflammatory response is also well known. Our group and others have shown that during elite control, inflammation persists. It's associated with CD4 decline. It's associated with heart disease and so forth. Also, and this is data that's just now emerging, and this is very, at this point, kind of speculative, it's also becoming, I think, possible, if not clear, that the inflammatory environment that exists during elite control is bad for maintaining control. Okay, now this is an incredibly important point, when I'm going to come back later to how we're going about achieving durable remission. But during elite control, having an inflammatory response is the only real predictor of people who subsequently respond. So the inflammatory, or who subsequently rebound. So if we want to maintain control, once we achieve it, then we're going to have to deal with this chronic inflammatory issue. And how we're going to do about, what we're going to do about that, again, is going to be the focus of my talk soon. So what I also think the field needs to be doing is shifting away from these elite controllers, because I don't think they're a perfect model, to these other models of HIV disease. And there are these reports out there, and we've seen some, I know the Harvard group has seen some, everyone else is looking at this, of these rather exceptional or extraordinary, whatever term you want to use, but these rarely unusual people who acquire HIV, have acute infection, but then their reservoir goes down to extremely low levels, their antibody levels are practically detectable, their T cell activation levels are normal, they look like they have been cured or near cured. And this is this a unique subset of elite controllers, or somewhat different, or just along the spectrum? We don't know. But our group and other groups are really digging in deep to try to figure out what's happening with this group of individuals. But I think the way forward will also be informed by what's happening with post-treatment control. The story which I don't think many people believed in initially, but I think now there's consensus that it happens. And here's a case of someone in our clinic that we saw the other day. He was a 30-year-old man who was in Mississippi, I believe, acquired HIV and presented with a viral load of 10 million. Now, what we know about elite control is if you come in with a viral load of 10 million, you are not destined to be an elite controller, okay? So this guy looked like he was in big trouble. They put him on antiretroviral therapy. He was suppressed for about 4 or 5 years. He stopped therapy, and his virus never rebounded. So he is a classic definition of what now the Visconti cohort discovered of these post-treatment controllers. And what do we know about post-treatment control? Because I do think that this is really where we may need to be going to inform how we should go about with this remission approaches. So we were involved in this collaboration called the CHAMP collaboration that led with John Lee at Harvard. He published this in JID recently. And these data are consistent with what the French have found as well in the Visconti cohort. And what I find most fascinating about post-treatment controllers is that when they present, when post-treatment controllers present with acute infection, they are indistinguishable from non-controllers in both this study and in a study by the French, that during people who become post-treatment controllers have high viremia before ART. They are destined to not do well. You put them on ART for 4 to 5 years, and you've shifted the balance toward the host for reasons that are unknown, okay? And so they're not, so there's something fundamentally that treatment does that alters that natural history in a permanent way. The other thing, which is very important with the post-treatment controller story from my perspective, is that once you have achieved control and you have been controlling the virus for a long time, as compared to elite controllers, you're quite different, right? The HLA characteristics are quite different. The level of inflammation tends to be very different. Post-treatment controllers have low levels of immune activation, low levels of inflammation. The reservoir size seems to be low level. So the post-treatment controllers seem to have achieved that state that we're saying we really want in a cure setting, which is, again, low reservoir, low inflammation, and durable control. So just to summarize this, elite control, which everybody's been studying in the cure world, is achieved and maintained via potent inflammatory response, probably CTL, that has negative consequences. These other two phenotypes that I've talked about are quite different in that they have really low reservoirs in general and limited inflammation. And so knowledge gained about these two groups of people, I think, are going to be highly informative in terms of coming up with the next generation of cure studies. So what we've known from these studies is that if we are going to achieve durable control, if we're going to achieve a remission, what we're going to need to achieve in people is a low disease burden, low reservoir size, probably 2 logs lower than typically seen in a chronically infected people, low levels of inflammation, and a sustained host response. It's probably going to have to be CD8 mediated. As Charles says, I've been involved in a lot of discussions with people outside of the HIV world, and we have a lot of relationships now with people doing cancer research and increasingly people doing hepatitis B virus research. In those two areas, cancer research and HBV cure research, you have the same kind of issue. You have this persistent cell that is diseased, that's hard to detect, that's rare, that can probably only likely be cleared by using host-mediated immune responses. They're being developed in those two fields, and we are now actively taking knowledge gained from those two fields and applying it to the HIV world. And how we're doing that is the following. First of all, monkeys. So it seems like every week we're hearing about a different monkey study in which monkeys are given SIV, or typically SHIV, treated very early, almost invariably, much earlier than we see in HIV infection, put on and then given a variety of immunotherapies that all basically are designed to do what I was talking about, to generate usually CD8 T cell responses, usually with vaccine adjuvants, and so forth. And in these studies, we have found that, and I'm not going to go into them in any detail, that there are a variety of different ways to manipulate the immune system to achieve, in monkeys, post-treatment control, and in rare exception appears to be eradication. The major mechanism that sort of pops up through most of these studies is that ultimately CTL, as we might expect, is going to be required to achieve the outcomes that we want. Now, how do we translate this work in the monkeys and our work now in the natural models of control into the clinic? That's what I do for a living, and I'm going to give you a state of where we are in trying to do that. I will say up front that we've been trying to do this before. We've been working in the cure area sort of indirectly through therapeutic vaccines now for over 25 years. There have been, I think, over 100 small clinical trials now done with immunotherapy and vaccines in the context of treated HIV infection, and they have essentially all failed. There is hints of success, particularly with dendritic cell vaccines, but for the most part, everything that we've tried has failed. And why is that? Well, I think we have general consensus that the interventions that we've used before have not been particularly potent in terms of stimulating the types of host responses that we want, that the vaccines that we've used have generally led to responses to pre-existing escape mutants. And I think many of us in the field are aware, like has been discovered now in the cancer field, that the chronic inflammatory state, and importantly the counter-regulatory immunosuppression occurs, is actually blocking us from doing what we need to do, and also this issue of high virus burden and perhaps tissue sanctuary. So these are the barriers for now using immunotherapy to achieve a durable remission. There are probably other ones, but these are the ones that we know. And each of these are now actionable. And how are we going to go about it? Bnaps, right? So Michelle Nussenswag had a couple of studies in monkeys and now recently in people who's shown that if you take HIV-infected people who start therapy early, and these are the two people in the bottom right-hand corner down here, if you take people who start therapy early, you interrupt therapy, you give them combination Bnabs, broadly neutralizing antibodies. These antibodies maintain partial control of the virus, presumably generating immune complexes. The immune complexes presumably then generate potent CTL. This has all sort of been worked out. Some of this I think is experimental, some of it still remains theoretical. But this whole concept that you can generate CTL with the immune complexes, with the antibody and the antigen, and that after the antibodies wane, the virus is controlled indefinitely because you basically have vaccinated the people with these Bnaps. This is a viable and testable hypothesis that we are now working on in the context of a randomized clinical trial. Come back to that again. Vaccines. Paul Stoffels has shown up, and he's partially responsible, I think, for some of this work that Janssen has been doing to develop preventative and therapeutic vaccines. A very high-profile paper from a couple years ago was done by the Dan Baruch's group, where they showed that in the context of treated monkeys, if you give a therapeutic vaccine by itself, it doesn't do much. But if you give a therapeutic vaccine that's given the right vaccine adjuvant, you can achieve, at least in some monkeys, post-treatment control. So this is sort of proof of concept in monkeys. There are other studies that by using either Bnabs or by using vaccines and vaccine adjuvants, we can generate CD T cell responses, we can control the virus. How are we going to be able to do this in people? And I'm not going to go into what's happening in people right now because every study that's been done so far has been completely negative. So I'm just going to say what we're doing through funding with, and this is sort of the UCSF virtual network of collaborators and friends. We have NIH funding, we have collaboratory funding, we have a very big AMFAR Institute for Cure that Rowena helps run. And we work very closely with the ACTG. And so we have either ongoing or funded and in development or funding is pending at least 5 different approaches that we are thinking that fundamentally are designed to generate a T cell response to conserved areas. These studies take long to get through regulatory approval, but we are in the clinic with a few, and we're getting there with the other ones. And the readouts, of course, are going to take a couple years. But that's what we're doing, and other groups are doing similar stuff. So there's a big family of experimental medicine probe studies, all designed to generate CD T cell responses to the virus. But none of that's going to work on its own. Every single study that I just showed you is almost guaranteed going to fail to achieve post-treatment control. In fact, in several of those studies, we're not even actually stopping therapy because we don't think this is going to work on its own. So we need these adjuvants, or we need other approaches. And so we're quite intrigued, but moving very, very slowly in terms of combining vaccines with immunotherapy from the oncology world, in particular with strong interest for quite some time of using PD-1 inhibitors, not only to enhance the CD T cell response, but also perhaps to reverse latency. We are working with Gilead, and we're working with a company called Moligen in Germany with vaccine adjuvants, TLR7 agonists and TLR9 agonists. One of these studies is completely enrolled. The other study is about to start. And now we're also beginning to work with IL-15 that we think is going to be potentially important in disrupting the follicle, the sanctuary that I mentioned. And so this stuff is all basically now in the field, funded and generally ongoing. And some of the results from some of the studies will be presented at CROI in a few months. But I want to get back to this thing, because I think there's a lot of expertise in the room about this issue. So we do think, I think, and I think others think, that this persistent inflammatory environment that occurs during treated HIV infection is a problem. The inflammatory environment that exists in cancer cells has been shown to be a problem in terms of immunotherapy in cancer. There are multiple different pathways that have been shown in the cancer field to be potentially harmful. including upregulation of checkpoint receptors and these myeloid-derived suppressor cells, Tregs, and so forth. And there is a robust, massive investment from industry to trying to block all these different pathways to enhance the capacity of the immune system to work better. And many of these things are now being transferred into monkeys for SIV and even humans for HIV infection. And here are some of the studies that we're involved in. We've been quite intrigued by using mTOR inhibitors in this setting. We've completed 2 studies, both of which were presented at CROI. We are quite interested in looking at the role of interleukin-1 beta, which has been shown to be very promising anti-inflammatory drug in the general medicine field, and we've completed a study of this in the context of HIV infection. And I've been working with Ray and Christina, I think, is going to have an update on some of the work with JAK inhibitors later. But I've been involved also in helping study these JAK and JAK inhibitors in the ACTG, and that study has been completely enrolled, and data should emerge hopefully in the next few months. But I'm going to end now with this perspective, and I'm going to say that each of these approaches that I've just outlined all need to be done, all have to have safety studies, all going to give us PK/PD, all of it's going to give proof of concept that they do what they're supposed to do, but none of them are going to have any impact, in my opinion, on what happens when you interrupt therapy. And the only way to move the field forward to see if any of this stuff works is to begin to do combination studies. And this is where there's a lot of contention in the field. Should we do combination studies? Should we do A and B? Should we do A versus B? And this kind of thing. But from my perspective, I think we should all now be jumping into this and doing studies that actually we think theoretically could work. And our approach, real quickly, in the AMFAR Institute is to basically, based on what we've seen in the monkeys, and to a certain extent in those controller models, we are going to bring 20 HIV-infected people into the clinic. We're going to vaccinate them with a DNA vaccine against conserved elements. We're going to give them a boost. This is very immunogenic in monkeys. We're going to then provide a post-vaccine adjuvant with a TLR9 agonist, consistent with what Dan Baruch had shown with his work with Janssen. And during that second period, we're going to co-administer Bnaps with the TLR9 agonist, because we believe during that period you'll also see latency reversal and possible clearance of the reservoir. This was also shown in another monkey study by Dan Baruch, and we're going to interrupt therapy in the context of treatment persistent antibodies to look for that vaccinal effect. We think that I think everything that can be done alone will not do anything except show what we think it will show. In order for us to basically figure out whether we're going to make any progress, I think this is the types of studies that we need to do, and that's what we're up to. And where are we? We submitted 1,000 pages for IND. The FDA was very friendly, gave us a really rigorous and quick review, approved it very quickly, and now we're waiting for some final steps, and we had hoped to be enrolling people in the next month or 2, but there's been some slight delays. And with that, I want to thank everybody in the audience for their attention, and I apologize that I jumped up here in front of Paul, who has arrived, who is the star of the show, and I'll turn it over to you. Thanks.
Thank you very much.